our speaker, Terry Hill, Executive Director of Rural Health Innovation. Terry has more than 28 years of professional experience working with rural healthcare providers and their communities. He is the former Executive Director of the National Rural Health Resource Center and currently serves as Senior Advisor for Rural Health Leadership and Policy. Now I'll turn it over to Terry.
Thank you very much, Kim, and hello, everyone. I'm joined today by Sally Buck, who is the Chief Executive Officer of the National Rural Resource Center. And I also need to tell you that Rural Health Innovations is a subsidiary of the center. Our center has been around as an organization for about 30 years, and Rural Health Innovations is the kind of the lead organization for this particular project. It is a small rural hospital transition project. It's funded by the Federal Office of Rural Health Policy, so I do want to acknowledge the good folks that work there kind of on behalf of rural hospitals and rural providers across the country. Janine Myers is our project officer, and she has been just an excellent person to work with throughout this project and in our previous project as well. We basically worked for approximately 13 years in 8 states in the Mississippi Delta on rural hospital performance improvement. Some of you on the call might have participated in those programs. And just this past year, we basically expanded the program nationally, and in essence are now working in hospitals pretty much across the country. Now, the project itself is basically intended to help in probably 4 core areas. The first is to help improve the financial performance of our hospitals. Particularly in this time of great transition, financial stability is going to be extremely important, so that's one of the major focus areas. A second is on creating a quality-focused environment, helping rural hospitals improve and then document their quality outcomes. Third area is really zeroing in on communities and community needs. And then finally, and very importantly, and what makes this program different from its predecessor, the Rural Hospital Transition Program, is that we are now, or the Rural Hospital Performance Improvement Program, we are now moving into a recognition that we are transitioning into a different type of payment system, a different type of delivery system as well. And so this becomes an important aspect of our new program, which is helping rural hospitals successfully transition into this new payment model that is also characterized by population health management. Now, part of our project, besides actually doing work in rural hospitals, and I'll talk more about that later, is to create educational seminars like the one we're holding today, and also tools and other sorts of resources that might be shared not just with our participating hospitals, but with this broader audience of rural hospitals that really are located throughout the United States. So those tools and strategies basically are being put onto our website, which we certainly welcome you to visit. Lots of really good educational offers as well. And then finally, to share information on how our hospitals can adopt these new best practices and strategies to help them transition into the future as well. So we're very much trying to take a very holistic approach. Although we're working directly on the ground with a limited number of rural hospitals, our major goal here is to help rural hospitals across the United States that might be in poverty areas or in professional shortage areas. Oops, I'm make back one here. So the objectives of our toolkit. So now we're going to talk about a rural hospital toolkit for transitioning into the future into these value-based systems. So what we're intending to accomplish with this toolkit is to provide financial, operational, and quality improvement best practice concepts and examples of successful actions and strategies. Not only the tools, but examples of what the rural hospitals that have participated in our projects have actually done, what they've learned. Learning from other hospitals about kind of how they've carried out these new strategies, and also taking some of the wisdom from our consulting groups and helping to translate that in such a way that other hospitals will benefit as well, and ultimately allow the successful transition into the future. Our audience, our intended audience, we have two major audiences. One are all of the small rural hospitals throughout the United States. We're particularly focusing in on those that are in poverty areas, but rural hospitals pretty much across the United States can have access to these tools and resources. We're also supporting rural health networks as part of another project that we're working on, where we support over 100 rural healthcare networks, and so that becomes a second piece. And it's available, it's intended both for critical access hospitals and for other prospective payment hospitals as well. These concepts are adapted to both types of payments. As I mentioned before, we're capturing the consultant best practices. You know, a lot of what consulting groups do is to use these best practices, bringing them from one hospital to the next, we think that's great, especially if you have great consultants like the ones we've been working with. But it really isn't getting these concepts and best practices out to a wide enough audience. So that's why this toolkit is coming in as being something that we think is going to be valuable. It's also going to incorporate the feedback from the hospitals themselves. This program is under the assumption that good consulting needs to be paired with good follow-through on the part of hospital leadership in order to produce the desired results. It's really a two-way street in a partnership here. And consequently, we've adopted a whole new kind of evaluation process where Rhonda Barkas of our staff, and she is basically partnered with Bethany Adams, who's our program manager. But Rhonda basically goes out and interviews hospitals in terms of what did you do, how successful were you in implementing these recommendations, where could we improve? And so we're constantly in an improvement mode. We're also assessing and evaluating what are the outcomes, what's kind of the so what of the consultations that we're doing. And it combines a lot of recommendations and actions with something we're going to talk about in this session, which is the Performance Excellence Blueprint. What we're suggesting is that when hospital leaders use this toolkit, they first do kind of an assessment about kind of where they are at this particular point. We're suggesting they ask the following questions. Taking a look, first looking at our Readiness Assessment, which I'll present shortly, to say what critical success factors are missing now in our hospitals. Is there anything we didn't think of here? This is going to present kind of a holistic approach to improvement and into transitioning into value. And so we're suggesting that the Readiness Assessment is going to give you answers, or is going to allow you to provide your own answers about what success factors are missing, what best practices might help your hospital improve that performance. And we're going to embed in this toolkit, as you'll see, a lot of best practices that you can simply click on and go directly to tools, resources, educational programs, etc. What best, so besides the best practices, what strategies might be used and organized into a framework to increase the efficiency? One of the things you can get right out front from us is that we believe in frameworks. There's several that you could use, but we're going to present one today that we think really makes sense. And the reason we think this is important is because it allows you to manage these critical success factors, to measure them, et cetera, and to kind of drive performance on a continuous basis. And then how have other rural hospitals done it? Again, one of the things we've learned through the 14 years and now working directly with rural hospitals and performance improvement is that most hospitals learn best from other hospitals. We try to honor that and embed it into this toolkit. So in essence, there is a self-assessment. Won't take that long to do. You would grade yourself or assess yourself on a scale of 1 to 4. We're suggesting one of the questions we were asked is, where do we start? What are the most important pieces? If you're telling us there's a bunch of things to be doing, what are the most important pieces that we could be addressing? And our answer to that is look first at leadership. It's generally always about leadership up front. Get your leadership aware, get the leadership's kind of squared away. We'll talk a little bit more about that in a minute. And then look at operations and processes. We have got to be as efficient as possible in our rural hospitals. And this is a big part of what our small rural hospital transition program is about. It's what our RHPI, Rural Hospital Performance Improvement Program, was about. And in essence, those efficiencies are absolutely going to be critical. So let's move into the toolkit. Kim is going to show you. This is the assessment. And just kind of running through in very brief order here, what we think are really crucial pieces on the leadership side is the board has got to be aware of what is happening to the industry and how the hospital is going to need to change, how it's going to have to do things differently than it might have done 5 years ago, 10 years ago, et cetera. Without the board's buy-in, we're seeing some real obstacles out there. So it absolutely makes sense to get your board on board, so to speak. And we're suggesting tools and resources that you might be able to use. A second major piece is to get your leadership staff and your managers, your department managers, kind of aware of what is going on and aligned as well. And then finally, very importantly, it has to do with primary care providers in particular, making sure they are a part of the leadership, making sure that we're partnering with them, et cetera. Strategic planning, basically, just a couple of quick things on that. We've got to start incorporating these value-based strategies into our strategic plans, and we've got to create a vision into the future. That vision has got to be compelling. It's got to be able to be understandable by our staff as well. Patients, partners, and communities, again, we're moving into an era where we're going to get paid for customer service. It's always been a strength for rural hospitals, and we've got to keep that advantage over urban centers in terms of patient satisfaction. We've got to develop new partnerships with public health, with mental health providers, with long-term care providers, et cetera. And we've got to work in our communities as well for a variety of different reasons. So we don't have to do that all at the same time. We don't have to do everything. We've got to be thinking about it moving forward. On the measurement, feedback, and knowledge management side of it, everything, we're going to have to be held accountable. If we're a critical access hospital, we need to do everything we can to keep our critical access hospital funding and those sorts of advantages. But we're going to have to start documenting our efficiency, documenting our outcomes, et cetera. And we're going to need to develop patient databases. It's many states out there. I just got back from Arkansas, and Arkansas is in a extremely rapid movement into value and population health management. They're in the midst of it at this moment. I know Oregon as well, we're seeing states across the country moving in this direction as well. We're going to have that patient database. And we don't have to create it overnight. We've got to figure it out. Operations and processes, workforce and culture, both of those are extremely important, getting our staff prepared, getting the teams in place that we're going to need, et cetera. And then impact and outcomes of our organization. We're going to have to report quality. We're going to have to report our outcomes. We're going to have to benchmark ourselves, not only against our competitors and our partners, but benchmark ourselves against our own performance as well. So that's the assessment. You take that, you identify areas where there might be room for improvement, and you then look to the toolkit, which follows to see, okay, where can I kind of strengthen this? So what you see here on your screen is the critical elements here on the left-hand side, and then the best practice recommendations in that next column. It's about getting your board of directors aware of where the industry is going, about the triple aim, et cetera. And what you see on the blue is just basically you click into that, and there are going to be tools, resources, education, et cetera, that is going to be there to help you. So I'm not going to tell you, go to Harvard Business School, look up this particular textbook. This stuff is intended to be available to you kind of at the click of a mouse. Again, you can just scroll down a little bit on that, if you will, Kim. Stop there for a second. So, and then the third column has to do with how hospitals are implementing these best practices. Again, this information is gleaned from our interviews with the hospital leaders themselves, some of whom are on this call, and we're going to hear from in a few minutes. But in essence, it kind of is that feedback from the hospitals in terms of, this is how we struggle in this one area. Here's something we did that really worked. It's the kind of feedback that we think is really important from our rural hospitals. And then on the right-hand, the far right-hand side are, again, tools and resources. And you can see, if you'll scroll down a little bit more, Kim, yeah, stop right there. There's strategic planning at North Sunflower Medical Center. So North Sunflower Medical Center, which is an excellent hospital in Mississippi, is providing this tool, this resource. We see Markham and Wallace's Memorial Hospital, a really good hospital in Kentucky, basically, talking about their performance excellence as well. We have spotlights, a performance management group calls, webinars. It's really very rich in resources that we feel are going to provide value. And it's taken us, it's 14 years of experience. We have a pretty good feel for how hospitals use these resources, how they're limited in terms of time, and how they generally need one click at two at the most, but generally it's one click moving into that. And so this is very real stuff, and again has been field tested with our rural hospitals as well. So go down a little bit more. We get into, stop there just. So these are recommendations of patients, partners, and communities. You can see develop affiliation strategies with other larger regional hospitals as a resource that's available for that. We also say refer to, we've got an appendix, we'll show you lately. Coordinate with local provider network. Again, every time you see a blue section here, you click into it and you've got resources available as well. Okay, go down a little bit farther. And then there's kind of the working with the community, preparing for population health management. Stop there just a second. Patient-centered medical homes. Again, I was just in Arkansas last week, and the majority of the Medicaid business in Arkansas and a good part, apparently, of Blue Cross Blue Shield business is being generated through these primary care medical homes. The concept is one that is really at the heart, and that and care coordination is really at the heart of these value-based payment models. And we should say that we're not just talking about Medicare or Medicaid. There's every indication right now that the other third-party insurance payers, Blue Cross Blue Shield, United Healthcare, Aetna, et cetera, are all moving in this direction of value and transitioning, et cetera. So tools and resources that help us create these patient-centered medical homes, explain to our board why it's important, help us look at community health status indicators in terms of our population health management. We think those are extremely important at the moment to be looking at and finding these tools and resources. Okay, keep going. Measurement, feedback, and knowledge management. You're going to see on the left-hand side again the indicators or the critical success factors, recommendations in that second column about what the consultants are basically suggesting, resources and tools there as well. The third column basically gives us kind of recommendations from our participating hospitals, their experiences, et cetera. And finally, the fourth column really gets into tools and resources. Okay? Keep going, please. The next is in workforce and culture. Again, tools and resources put in there for you to access. Okay. Operations and processes, really, really essential is that we make our business processes as efficient as possible, that we maximize the effectiveness of our revenue cycle management. We continually improve quality. Here's where you would use tools and resources like lean process improvement, maximize information technology in this piece as well. And again, we have the four columns, and particularly with the tools and resources and educational pieces and performance management group calls, newsletters, et cetera, on that side. Okay, keep going. Keep going. Lots of stuff in processes, as you can see. It's been a big focus for us. Impact and outcomes, the final segment, and this again is based on the Baldrige framework, but we're putting in value stream mapping, 5S workforce organization. So here you're going to find a lot of tools and resources that are going to help rural hospitals kind of measure and then report and publicize their value. It's where the value really shows up in terms of outcomes. Okay. Okay, these are the appendices. We want to talk first about the Performance Excellence Blueprint. Again, we're finding that some sort of a framework is essential here. You can keep going through this, Kim, if you will. It just talks how does the blueprint, how is it used. The Baldrige framework, let me tell you, has been the kind of the gold standard for performance excellence for years and years and years. And a lot of our rural hospitals are now using Baldrige. We've had quite a number of Baldrige Award winners that have been rural hospitals and urban hospitals as well. We think it is the most tried and true framework out there. It doesn't have to be complicated. What you see now are the components of that performance excellence framework, and in essence, they include all of those factors that we had put into the initial framework that you saw. We just want to let you know that this toolkit is based upon a very legitimate, extremely valuable framework that we think is going to be crucial to the successful transition into the future. Okay? Oh, okay, now we've got some folks on our call, we're going to, these are the hospitals that were selected in 2015 to participate in our small rural hospital transition program. They are hospitals from New Mexico, Arizona, Kentucky, New Mexico, again, Arkansas, Nebraska, Mississippi, and South Carolina. We have, there's the map kind of showing where they are across the United States. And if it was possible, we could have probably put another 100 into there. That's again, what we're trying to take the learning from our experience in those hospitals and kind of translate it in as well. So we've got a couple of hospital folks, hospital leaders on this call, including Elizabeth Walling from Markham and Wallace Hospital, which is in Kentucky. And I'm going to ask them to talk a little bit about how our small rural hospital transition program kind of fit into the work that they were doing in terms of moving into transition, into strategic planning, et cetera. So Elizabeth, would you start by talking a bit about the experience that you had with this program, and just a little bit about the transition you're making now into the value-based reimbursement system?
Certainly. Thank you, Terry. First of all, I just wanted to say thank you, of course, to the National Rural Health Resource Center for the opportunity to participate in this project. We were familiar with the consultant group that we were working with, Stroudwater and Eric Schell and his team. And so the population health framework that Stroudwater uses was something that we were familiar with, and we're very excited to have the opportunity to participate in this program. From the overall assessment, a lot of the things that were identified in our recommendations really work to confirm our strategic direction for our hospital and looking at the initiatives that we have in place to transition to a value-based model. Some of those things included some of the things you've already identified, including the need for additional opportunities to align with physicians, showing how the primary care basis is of value to this new model, and the number of covered lives that we have currently in our facility. And then, of course, looking at one of the most particular things that was, I think, from what we understand, clearly specific to our facility. Oh, Elizabeth, did we lose you? Terry, are you still on?
I'm still on.
Oh no, I think we might have lost Elizabeth. Maybe we could speak with Gregory.
Yeah. Greg, are you on?
Greg, press *2 to unmute your line.
Here we go. Can you hear me now?
Yes, thank you.
Okay. And you're looking for some of the things that we're weaving into our strategic plan?
Yeah, Greg, I was out at your facility in the first session we had with you, and talk a little bit about how the site visit and the help that you got from the Stroudwater group help you to put together your strategic plan, and particularly any aspects that might be preparing you for the new value-based system.
Sure. No, I'd like to thank everybody for the opportunity to speak, and just to give you a little history, all of us on the leadership team are relatively new. I've only been here 2 years, and people on the leadership team have been here longer, but they have never been in a senior leadership position. So the last strategic plan that was in place, I believe, was about 2010. So what I did is I put together a short-term bridge plan, knowing that the small rural hospital transition project would start. And that really provided a wonderful springboard for us, to look at where we are and where we needed to go to move towards, population health. We're in a very rural, poor county, Apache, and the hospital does well, but we don't have a lot of resources, so to go out and hire consultants to help us was a little out of the question. So this provided some excellent resources. I've worked with Eric in the past, and Terry was out, and Lindsay, and I think what really, the first thing that happened is that it really provided us an opportunity to sit down together as a leadership group, but also when you folks came back in June, to sit down with the management team, the entire management team, our department directors and the like, to craft, our 9 most important areas that we needed to look at. And that was, we came up with 9, and one was primary care alignment. We lost 3 physicians from our service area. We have a FQHC in town, North Country, and they lost 3 physicians, which pretty much impacted us directly. So now it's up to us to look at recruitment. The other one was revenue cycle management, grow our outpatient services. One thing we really depend on is our swing bed program, and our average daily census with that was around 2, and since we've started to institute some of the recommendations, marketing and contacting other physicians and the like, we've seen lately an average daily census of about 6. So that really has helped. The one thing we don't have is we don't have any on-site surgeons. So Sholo is the next largest town, and so we have them come up and work in our specialty care clinic. Staffing models, we're employing 2 nurses on the med-surg floor and 2 nurses in the ER, and walking away, we looked at a resource nurse, plus 1 nurse in the ER and 1 on med-surg, and then the resource nurse could float back and forth. The other thing, too, is the hospital has been through some hard times, and people haven't forgot what happened 10 years ago and things like that. So, the one thing we need to do is just, stress the quality of our care. The last HCAT survey, we were 7th out of 80 hospitals in Arizona, so we have a lot of good things to talk about. Strategic plan development was another one, and 340B program development. But what it really did is provide an opportunity for all the directors and the leadership team and everything to work together and be challenged by Eric. And I think that was one of the nice things, is that we didn't go out and hire anybody, and nobody felt like Eric didn't feel like he had to worry about his fees or anything like that. So he was in a position to really challenge us in a nice way and really made us think and the like. And so we came up with quite a few recommendations, and out of those 9, there is a myriad of strategies and the like that we're going to be weaving into our strategic plan. But we've seen results already, and it was great. It was good board education too. We folks were out. Eric spent an evening with the board and actually went through the movement, the AAA, and the movement from the fee-for-service paradigm to population health management, and where we needed to start, and the steps along the way. So it wasn't as if, oh my God, we had to do this 6 months ago. And it was like, no, it's starting to happen, and here's what you have to do to be successful in the transition. So that was very helpful.
Greg, the basic concept as we work with hospitals across the country is that in essence there is pretty much a tried and true formula here. That in essence the sort of things that you've talked about, the educating of your board to get them aware, to look in at your swing bed program, for example, if you're a critical access hospital, and it's really terrific to hear that. The other thing about the swing bed program is you don't have any nursing homes in your community, meaning it's an untapped resource that is really important for your patients and the folks in your service area as well. So the use of swing beds and how to maximize that or how to use it appropriately becomes really important. The revenue cycle management side of it, the side that helps promote the hospital services, those are all pretty much parts of what we see as this basic strategy. And in essence, we think it can be translated to other hospitals that might not have the benefit of being chosen to be a part of this project. But give us some feedback a bit. I know you had a little bit of a chance to take a look at what we're trying to do here, but do you see value in sharing some of these approaches, some of these tools and resources with other rural hospitals out there, again, that might not have access to the kind of consulting resources that you've had through this program?
Oh, definitely. It was Bethany Adams, Lindsay Corcoran, and myself. We were asked to give a presentation at the last Arizona Rural Health, the Flex meeting in Tucson, and it just it was phenomenal because people were really impressed at some of the things that we were doing, and we've been again sort of an unnoticed hospital sitting up in the mountains of Arizona with really not a lot of things happening, and all of a sudden this provided quite the springboard. And I think the other thing it provided was data. Stroudwater did a lot of data mining and presented us with data on our market area, data about ourselves, data on where the market is going. And that really provided direction for us. And, again, I think none of this is what I would deem rocket science, but it is very fundamental and would benefit any hospital. And again, it's just a matter of taking the suggestion, making it fit, and what's nice is that all the staff was involved in developing an action plan. So if we're looking at primary care alignment, like an RHT assessment, PCP recruitment, functional alignment, the action plan said investigate recruitment regulations, increase primary care services to exceed 50% of services in our specialty care clinic, create a physician recruitment committee, which we have already, hire primary care extenders, assess the location of the primary care clinic. So it was nice because each one, we're able to drill down on the suggestions and provide action steps with timelines. So to tacticalize this whole approach, and it just made it so much more doable.
Let me see if Elizabeth is still on. Elizabeth, have you been able to rejoin us?
Terry, I just spoke with her, and she's trying to call in on her cell phone. So
Okay.
hopefully
Okay.
she'll be on the line soon, and it's *2 to unmute your line.
Yeah. And the reason we wanted to speak to Elizabeth in particular is, first of all, really congratulate Greg on the job, the leadership that he has done for that hospital. There's been pretty dramatic change, and boy, this was just last spring when we did this work, tripled the swing bed usage, and it does take follow through on the part of the hospital. There's no magical formula here that to accomplish this work without really a commitment on the part of the hospital itself. And again, I want to applaud the leadership in the hospital as well. All of these pieces need to come together to produce sustainable performance as well. One of the things that we find, you get really good hospital leaders like the hospitals that we're profiling right now, but it's so important to embed the culture, the processes, et cetera, into the hospital, so they're kind of to hardwire it, as the Studer folks say, to hardwiring excellence, that because we have such rapid turnover, or unfortunately high turnover, in rural hospital CEOs as well. So part of our intent is to not only to work with the hospital to assess how the degree to which the changes have been bedded into the hospital itself, and then to leave with some tools and resources that could be used in their training programs and in their transitions of leadership as well. So again, I'm always so impressed by the type of leadership we see in our participating hospitals, and I do want to applaud that. And again, the work is hard, but the rewards specifically in terms of improved financial and quality performance are absolutely there. Elizabeth, are you back in yet?
Yes, thank you, and I apologize for what happened.
Elizabeth, can you talk just a little bit about your experience? And we're very particularly interested in how you're moving into more care coordination and primary care home, et cetera. Would you talk a little bit about that and how perhaps the framework was of use?
Certainly. Again, we were familiar with the population health framework that Eric Schell presents. And first of all, I'll start off again by saying that we are part of a much larger system. We are a critical access hospital, but we're part of Mercy Health out of Cincinnati, Ohio. And we're one of 4 critical access hospitals in our system. And so as we transition to this new value-based model in healthcare, and being in a system that is really a PPS-centric health system with all the, we're outnumbered with a number of larger hospitals in our system, being able to define our role as a critical access hospital and move forward with the direction of our system has been a challenge for us. So this was truly a benefit to have Eric and his team come in and be able to help confirm and really define our role as a critical access hospital and how we can move forward in our strategic direction into this new model. So again, looking at our primary care and being able to identify new opportunities to align with new primary care physicians in our market area that we really had not identified before, and being a critical access hospital in this area. Then also looking at, again, how those lives the covered lives and moving toward the patient-centered medical home models. We have 3 different outlying primary care clinics in our service area that we own and operate, and they are level 3 patient-centered medical homes, which again was an initiative that was driven by our system, being part of a larger system, but seeing how that will bring value to our facility as we move forward in this model. And then also identifying ways to look at key areas that we can grow. I know when I came in earlier on the call, I heard you talking about our swing bed program and the growth we've seen there, continuing to look at financial opportunities so that we can ensure that we are financially stable as we transition to this new model. Not only our swing bed growth, but looking at growing our primary care, bringing on new providers, creating new alignments, looking at our 340B pharmacy program. I think we identified some significant opportunity there for our critical access hospital. And then strategic pricing was an issue that we identified as well, that we're not only our facility, but some of the other critical access hospitals in our system are also identifying as an issue, and the impact that's making on a critical access hospital. And as we move forward to this new model, what are the changes that are needed? So again, this was an invaluable experience for us to be able to sit down with our board and our leadership team and even some of the executive level members of our health system to provide a clear strategic direction for our hospital as we move forward into this model was just a great opportunity for us.
You know, Elizabeth, speaking of the swing bed program, another example, this is not within our program, but another really good example that we have seen about the growth of swing bed programs comes out of the Mayo Clinic, the hospital that is actually based in Minnesota. And they have I think 12 hospitals in their rural hospitals in their system. And they went into 11 hospitals participated in a post-acute care program with their swing beds. And in the course of, the Mayo invested in teaching the hospitals how to do effective care coordination, how to do post-acute care, et cetera. And they then started sending patients out of Rochester, in other words, out of the heart of Mayo's healthcare system, out to their critical access hospitals into the swing bed program. And it was very, very successful. The number of swing bed days doubled and tripled. The financial performance of those hospitals really improved as well. There was significant benefit to the Mayo system itself, and it's all documented in a report that they've done as well. So swing beds from a critical access hospital program, we think fit very, very nicely into this transitioning into value. They have value. In the value-based system, kind of the accepted wisdom is we're going to want to take care of local people in local hospitals in that regard. So we think that this is very promising for rural hospitals, but we have kind of a dangerous period here over the next several years as the transitioning of the payment model takes place. What is on your screen is something, again, that our consulting group, the Stroudrider group, came up with, projecting the transition of this payment model. Part of the accepted wisdom here is you've got to align your delivery system and the way it's being presented with the payment models themselves. So in that first phase one, we're starting to create the capacity for value. We're aligning ourselves with our primary care physicians. We're starting to look at care coordination. We're reaching out to our community. We're developing kind of a service network, et cetera. And what you see there in Appendix C is this projected phases of where the market will be going. So again, we want to make sure that as providers, we talk about crossing the shaky bridge. In essence, is that the shaky bridge is kind of this payment system into the future, and it's going to be extremely important to prepare our hospitals to be successful before we race across that bridge. So that's what this program, our Small Rural Hospital Transition Program, is about, and it basically is helping to prepare hospitals to be successful moving over into a time where there are three major sources of payment: Medicare, Medicaid, and insurance payments are all going to be under this value system. And the tools and resources are hopefully are going to be very helpful in that transition. Appendix D is something else that came out of the program, which is about affiliation continuum. It's a chart. We very often in the toolkit and on our website, we have educational sessions that help explain these models. Next slide, Kim. And these are some additional online resources that are there. Again, Pathways to Value with Population Health, Rural Health Virtual Training Gateway, Rural Health Value Tools and Resources. There's just, that's kind of what we're doing. We're working in partnership with organizations like the Rural Policy Research Institute. There's a value, the initiative. What I can tell you is that the national partners are working together on this project, and the Rural Assistance Center becomes another really key partner here as well. Next slide. I'm going to invite Sally to
we'll go back to the slide deck. Again, thank you, Greg and Elizabeth, for sharing your reflections on the program and some of the outcomes you're realizing. Even in this first year, they were both part of the 8 hospitals selected in the transitions program. This year, the Small Rural Hospital Transitions program will be entering its second year at the end of September, and we will have a new application cycle beginning September 29th, and the application link will be promoted out to all eligible hospitals, and those are hospitals under 49 beds in areas of persistent poverty, and that covers 20 different states, primarily the Delta, the Southwest, and a few in the frontier area. And we'll also be promoting that to the state offices, the Rural Health Hospital Association, so they can help you determine eligibility. You can also do that from the website as well to determine if your hospital or hospitals in your network are eligible for the on-site consultation. And the application is an online application. It includes the blueprint self-assessment, actually, so that will be familiar in terms of looking at the 7 areas of preparation for performance improvement, and then your hospital would select whether you're interested in financial and operational assessment or quality improvement assessment, and the participation expectations requirements are included as well. And the toolkit has highlighted the best practices that were recommended from the field experts who do these on-site consultations, and then, as you saw, the hospital action steps were as a result of the recommendations and from both the Rural Hospital Performance Improvement Project as well as the Small Rural Hospital Transitions Project. So you got a sense of what kinds of recommendations were made and then the action steps those hospitals took. And so if your hospital is interested, again, you can watch for that at the end of September, and that cycle is open for 3 months to complete that.
You know, Sally, and I'd also recommend if those of you on the call have not seen some of our earlier educational presentations, we have them available online, specifically the ones on population health. There were quite a number this year that really stood out in terms of, you know, absolutely superb kind of overviews of what is population health, what is the rural hospital's role, how can we maximize their efficiency, how do we get across the shaky bridge into the future, et cetera. I would encourage you to go back and if you can, look at those specifically that are dealing with this transition. A lot of them will be on the toolkit, but we're going to continue to you know, find the best speakers, resource folks out there in the future as we put together a whole new series of educational events. And again, if you don't have the time to listen to them or watch them in person, we basically are storing them, and they're very easy to access as well.
Are there any questions? We have time to take questions. You can either star 2 to unmute your line or put those in the chat box. Not hearing any. Again, I want to thank Terry Hill for presenting the toolkit and the Small Rural Hospital Transitions team for developing the toolkit. And thank you, Elizabeth and Greg, again for sharing your stories. And we do have a link up there on the final slide to complete a short assessment, give us feedback on the presentation, as well as suggest topics for future webinars. We'll be developing our topics for the next program year, and there'll be at least 16 webinars